So good afternoon, everyone. And thank you so much, Alex. Before I say anything, though, about the National Federation of the Blind of Pennsylvania, I do want to share that I have a day job. I currently work as the community training specialist for Associated Services for the Blind in Philadelphia. We offer educational and enrichment programming for individuals experiencing any type of vision loss along the vision spectrum. ASB also offers community education opportunities, such as our Family, Friends, and Professionals workshop, sensitivity training, and what is ASB and what do they do? In my volunteer life, I do serve as the elected president of the National Federation of the Blind of Pennsylvania, and the NFB is the largest nonprofit consumer organization of blind individuals in the country. So I use the services personally of accessible pharmacy services, and I kind of fell into them. I opened my email one day and I saw this email from this organization, Accessible Pharmacy Services for the Blind. Wow. So I just started reading this, and I'm reading the address, and I'm like, wait a minute, I know where that is. So I said to my husband, hey, is this the address for our pharmacy? Well, so it was. So began my relationship with Accessible Pharmacy Services in April of 2021. And I do have to say that they have not missed a month in delivering my prescription meds. I also want to share that my husband also gets his medication through Accessible Pharmacy, not because he's blind, but because if there is anything that would happen to him, I at least have the ability to know what medication he's taking and when he's supposed to be taking it. So the service is invaluable, not only if you're blind and you are the medication taker, but if you are also managing medication for another individual in your family. So that being said, at this time, I am honored and privileged to introduce our next speaker. Jason Barrett is the Chief Medical Officer for Accessible Pharmacy Services for the Blind, and he provides prescription medications and healthcare solutions to patients with disabilities. Jason earned his doctorate degree from the University of the Sciences and is a licensed pharmacist. I have known Jason Barrett for over 25 years, and his high level of professionalism, of his professionalism and that of his employees is commendable. So without further ado, Jason, it's all yours.
Lynn, thank you so much. I'm blushing. I'm just a tad bit embarrassed. As an aside to everything else, if you don't know Lynn Heights, then you've missed out, because she is one of the most genuine and high character individuals I've known in my life, both as a person and as a patient. It's been nothing but wonderful to know you, Lynn. I'm sorry that you've gotten mixed up with Andy and the rest of us, but we're certainly better off to have you. So thank you very much. I want to thank basically everybody that's been part of this webinar today. I've sat back and I've observed all of this, and as the Chief Medical Officer, I'm just blown away. I'm so blown away by how well everyone came together today, the contributions that they made, and really the unbelievable amount of fantastic information. The one thing about Accessible Pharmacy Services that we have been so certain to dedicate ourselves to is really educating, empowering, and providing a really inclusive opportunity for patients in the blind and low vision community. And everyone that has spoken today and all of the folks that have made this possible really exemplify that effort. So again, I just want to say thank you to all of you, and thanks to everyone who's on the webinar and that is taking part in this. So from a broad perspective, what I'd like to do in terms of diabetes medication and the devices used to test blood sugar or otherwise is demystify some of what I would call the murkiness around it. Diabetes is extraordinarily important. We're going to talk about some statistics in a moment to give you, I guess, a better sense of why that is the case. But there's no reason for anybody to look at diabetes as, an impossible task to deal with or overcome. And Accessible Pharmacy Services, because we are who we are, has dedicated our entire platform to really opening the door for patients in the blind and low vision community to understand things like diabetes, feel a true sense of the relief of burden, and have a resource and an environment where they both feel included, but also understood, and knowing that there's never a time where we're not continually trying to provide you with the highest level of service possible. So having said that, just going to sort of talk about some statistics in general with diabetes. As crazy as it is, there are 34 million people in the country with diabetes. That's approximately a quarter to a third of the entire, 10% of the entire population. 34 million. And 88 million people are in a state of pre-diabetes. That's where I was getting the third from, 88 million people. Now, what's really unbelievable is that 1 in 5 diabetics don't even know that they have diabetes, and 8 out of 10 of the folks that are pre-diabetic don't know that they're pre-diabetic. So it's really an extraordinary statistic to think about how many people are affected. Now, we separate diabetes most frequently in terms of type 1 and type 2. We're going to talk about this in greater detail, but type 1 generally are the folks that need insulin, and type 2 are those that are managed with a series of other interventions. Having said that, 90 to 95% of the diabetic population are in fact type 2. So it's actually a very small number of individuals who have type 1 diabetes, and it's important to consider that. So what's at the root of diabetes anyway? So what is the one thing that we hear so often? That is sugar. Sugar is the topic that everyone talks about. And the reality is sugar is one of the very many carbohydrates that we can ingest on a daily basis. There are 3 types of carbohydrates. There's sugar, there's starch, and there's fiber. Your body needs all of them to function well. Normally speaking, sugar and starches get broken down for energy and put into our cells and our organs. Fiber is a little bit more of the odd man out. It basically passes through the body, mostly undigested and mostly changed, but it does have a role. When your carbohydrates, your starch, and your sugars are digested, they break down to their final form known as glucose. And glucose is what our body likes the most for energy. So our body breaks down the carbohydrates that we eat, except for the fiber, through a series of processes that we're going to talk about, and then into glucose to be put into the cells and create the opportunity for us to utilize it for energy. So what happens when you eat carbohydrates? Well, carbohydrates follow the same track from your mouth to their final destination. The steps and the length of time it takes to get them there depends on the structure of the molecules you're starting with. If you're eating sugar, which is, basically a single molecule or 2 sugar molecules bound together, it's pretty close to glucose. So there's not much for the body to do there. However, having said that, if you're eating a more complex carbohydrate like a grainy bread or a potato, there's several processes, and the period of time it takes to break down glucose is a little bit different because of the complexity of the structure. So amazingly, your body starts to digest the minute that you put the carbohydrate into your mouth. Your mouth has enzymes that begin the breakdown process. In fact, if you put a complex carbohydrate, like a piece of white bread, in your mouth and left it there, you'd find that it would start to taste a little bit sweeter because your mouth and the enzymes are breaking it down to sugar without even chewing it. But after you chew it and you swallow it, it gets churned up and mixed with all these different kinds of, contents of your stomach. And then it gets passed along to the small intestine. The small intestine is where the real work begins, or shall I say, the heavy lifting. It's in the small intestine that body breaks down the carbohydrates into really tiny bits. And how long this takes really depends on the carbs that you've eaten. So like I said, the simple sugars are going to go fast, right? So if you eat a piece of candy, or if you have a glass of soda or a piece of fruit, that's not going to take a whole lot of time. And that's going to really, get to your bloodstream quickly. However, the starches and everything else hang around for a little bit while longer until they're finally broken down. Now, when carbohydrates are converted to glucose, they're ready to enter into the bloodstream. But first, they travel from the small intestine into the liver. The liver then dispatches most of the glucose to the body via the bloodstream. And some of the sugar is actually stored in the liver as well for later on. We're going to talk about that also. But when the glucose gets into your bloodstream, that's when our friend insulin is secreted from the pancreas. So insulin drives the glucose out of your bloodstream and into those important cells for use as energy. Cells in your muscles and your brain get the choice first, hopefully. But having said that, there's also sugar that's stored in your muscles and sugar that's stored in your liver as something we call glycogen for later on. And high excess of glucose piles up, can be stored in the body as fat also. So we want to be wary of that. And that's sort of the discussion that we often hear about people controlling their carbohydrates to affect their weight, but also to have what we would call better health. When you put your body into a deficit, your body will convert some of the stored sugars into glucose and release it back into your bloodstream. And of course, when you exercise, you drive some of that activity as well. So the role of insulin is basically to keep glucose in your blood within normal range. It helps to do this by moving that glucose into the important cells of your body for energy and into the liver and muscles for storage. So your pancreas basically reacts to blood sugar rising in your bloodstream and then releases the insulin after you've eaten a meal or carbohydrates, and as they begin to break down to perform this duty. So when you think about it, and the reason we're talking about this is because when we look at the medications, we look at the pathways and how sugar is, shall I say, broken down, but also utilized. So you have your body producing insulin, which is the necessary chemical to drive the sugar into the muscles. And then you have those tissues in the muscles, in the brain, in the heart, and so on that receive that insulin and say, hey, pull this glucose in and make it energy. So that's something to think about as we progress through both the types of diabetes, but also the medications and the way we would address diabetes and treat it. So in terms of diabetes, there's three specific kinds or types. There's type 1, there's type 2, there's gestational diabetes, which comes about when you're pregnant. But I also want to sort of mention pre-diabetes, because pre-diabetes as a state is not necessarily what I would call a disease, but it's a warning, or shall I say, a period of time where you really want to observe your health and start to do some things that would help you have better health going forward and potentially slow or even prolong the onset of diabetes. So type 1, which is often referred to as adolescent diabetes, is when part of your immune system, which would normally fight bacteria or viruses, attacks or destroys the insulin producing cells in your pancreas. So it's not exactly known why this happens, but under most circumstances, when this happens, your body's rendered with little insulin or no insulin production whatsoever. So therefore, the glucose builds up in your bloodstream and doesn't have the same ability to be pushed into those necessary tissues for energy or stored appropriately in your liver and in your muscles. So there's a number of possible genetic susceptibilities, environmental factors that could bring this about, but it's still unclear. Now, type 1 diabetes, generally speaking, is not weight dependent. So you really can't look at somebody and say, well, if they just lost a little bit more weight, they wouldn't have this position. But it's really more to do with other factors. Family history does play a role. While it's not a direct sort of inherited factor, the way that type 2 is, you do have an increased risk if one of your parents or your siblings has type 1. The environmental factors, obviously, we said a minute ago, are probably related to viral illness. So if you're exposed to viruses that would stimulate that reaction in your body to attack those cells, that's when really, we start to see the patients presenting with diabetes. There's also the presence of damaging autoimmune cells or autoimmune antibodies. Antibodies obviously is a very popular word these days, but some family members of patients with type 1 who have been tested have these antibodies. If you know that a person in your family has type 1 diabetes and they have been tested for antibodies, you might want to get tested yourself. Because if you have them, it does increase your risk. It doesn't mean that you have to get diabetes. Simply having the antibody doesn't guarantee it, but it's the kind of thing you want to pay attention to in case you start to have symptoms or if something takes place like an illness. So type 1 can really develop at any age, but it's most often appears at childhood or adolescence. Type 2, which we're going to talk about in a minute, and the most common type of diabetes is usually in people that are over 40, although it can take place at time in your age that's earlier. So in terms of type 2, your cells basically become resistant to the action of insulin. So you're still producing insulin, but you're either not producing enough to make up for the cell's lack of sensitivity, or you're simply not sensitive to it at all. So instead of moving the glucose out of your bloodstream and into the cells, the sugar starts to build up in your bloodstream. So it's not certain why this happens, but it's believed to be genetic and somewhat environmental as well. There are some cofactors, there are some risk factors to look at specifically and really keep your eye on. So some of those risk factors are weight. If the more fatty tissue you have, the more resistant your cells become to insulin. Being inactive also puts you at risk. Physical activity helps control your weight. It uses glucose for energy. It makes your cells more sensitive to insulin. And as we said a moment ago, family history, your risk increases if your parent or your sibling has type 2 diabetes. Also, increasing age increases your risk as well. It may be because you're exercising a little bit less, you lose muscle mass, gain weight, and so on and so forth. But generally speaking, if you have a lot of, I guess what I would call inactivity, if you're a little overweight and having more fat than you'd like, and as you age, it particularly becomes a problem. Also, if you've had gestational diabetes, in other words, if you got diabetes while you were pregnant, your risk of diabetes goes up. There are also some disease states that would be indicative of risk as well. Generally speaking, anything to do with your heart. I know it sounds kind of, I guess, disconnected a little bit that, your heart's here and your pancreas is in a different place, but people who have high blood pressure, people who have high triglycerides, high cholesterol, tend to be at a greater risk for diabetes. But people who have polycystic ovary syndrome also have higher risks. And those people who are being treated for any one of these issues should really think about talking to their doctor about being evaluated for pre-diabetes or diabetes as well. So in terms of gestational diabetes, during the pregnancy, the placenta produces hormones to sustain your pregnancy. These hormones make your cells a little bit more resistant to insulin, so naturally pregnancy is a risk. Normally, though, your pancreas responds, producing enough extra insulin to overcome the resistance while you're pregnant. But sometimes it can't keep up. And when this happens, too little glucose gets into your cells and too much stays in your bloodstream, resulting in gestational diabetes. So what are the risk factors? Well, again, unfortunately, it's age. So once a woman gets over the age of 25, they become at a higher risk. Your family, your personal history, you can blame it on your relatives. Basically, if we have a relative who's a parent or a sibling, a close family member that has type 2, you're at greater risk for gestational diabetes. Your weight, being overweight, in general is not a good idea, but especially when you're pregnant, puts you at a higher risk for gestational diabetes. So basically, we're going to see and hear something repeating over and over again. Good general health is always a good idea. And that's one of the things at Accessible Pharmacy Services that we're particularly passionate about. When people reach out to us and connect with us and seek any kind of information, we underlie all of our discussions with patients with good practices in terms of your health. It just always makes sense to take care of yourself. You're the most important person in your healthcare picture. So before we really get a deeper dig into the other types of diabetes, I want to talk about pre-diabetes. There's no clear symptoms to it. You may have it or you may not know you have it. But here's what's important. Before you develop type 2, there's almost always prediabetes. Blood sugars are potentially a little bit elevated, but not so high that you get the diagnosis, and you may have some symptoms or even some complications. But regardless, you've got to check with your doctor and get tested. If you discover you have prediabetes, it doesn't mean you're going to develop type 2. It really doesn't. But there are opportunities for you to intervene and start to do some lifestyle modifications that could slow or potentially even hold off diabetes altogether. So if you have any of those risk factors that we spoke of earlier, you should talk to your doctor about it. So aside from the fact that your blood sugar is high, well, what else is happening? What are the symptoms of diabetes? So type 2, the symptoms may not be so exacting and so powerful because the disease really develops over time. It gets gradually worse. Type 1, the symptoms tend to become very, very obvious. They come on quickly and very severe once your body's not able to secrete insulin anymore. So here they are. You've heard this a lot. Increased thirst. Anybody that has a, this is going to sound awful, but anybody that has a cat or a dog with diabetes knows the bowl is empty all the time. And you say, boy, that cat is really thirsty. Might be a signal of something. Frequent urination, extreme hunger, unexplained weight loss, fatigue, irritability, blurred vision, slow healing sores, and frequent infections, especially around the gums, the skin, or places where you've had very minor injuries. Also, the presence of ketones in your urine. We hear ketones a lot. What ketones really are, the breakdown of muscle and fat. And that happens when there's not enough insulin. Your body's basically not getting the energy it needs from your dietary intake. So it starts converting muscle and fat. And that will show in your urine as ketones. So those are sort of the really very specific symptoms. You know, in terms of testing and a diagnosis of diabetes, we're going to talk about that to be more exacting in a moment. But what's going on with diabetes? What are the complications? So let's say I have high blood sugar. Let's say I'm going to the bathroom a lot and I'm thirsty. Well, what are the risk factors? Well, the longer you have diabetes and the less controlled your blood sugar is, the higher your risk of complications. Eventually, diabetic complications can be really extraordinarily disabling or even life-threatening. So these include cardiovascular disease. We're back to the heart again. But diabetes dramatically increases the risk of a number of cardiovascular problems. Angina, heart attack, stroke, narrowing of the arteries. If you have diabetes, you're more likely to be affected by these and you're more likely to have a heart attack or a stroke. So we really have to protect our heart, and diabetes, to be very frank, is one of those, potential risk factors. Now, a lot of the other risk factors come about, or shall I say complications come about, because of the effect that diabetes, that high level of sugar or glucose, has on the microvasculature in your body. So the places that are most susceptible to damage done to those vessels are the areas they're going to suffer. Nerve damage. Excessive sugar can cause the walls of those capillaries, those little blood vessels that nourish your nerves, especially in your legs and your extremities, to be damaged. So you can experience tingling, numbness, burning, pain at the tips of your fingers or your toes that gradually can spread upwards. Okay, so if it's left untreated, you could really lose sense of feeling in your limbs. You don't want that. Damage to the nerves can also be related to digestive issues. That can cause problems with nauseousness, vomiting, diarrhea, and so on and so forth, and a lot of horrible things we obviously don't want to talk about. So when these things arise, you know that you've progressed to a point where it's really important to seek help. But those small capillaries are also present in your kidneys. Kidney damage is often associated with diabetes. So if you're, having problems with diabetes, the ability for your body to sort of filter fluids and, take care of even your blood fluid is compromised. And over time, it can damage your kidneys to the point where you could need dialysis or even a transplant. I know that we had a long discussion about retinopathy, but your eyes also have very small vessels that are sensitive to high sugar, and diabetic retinopathy is an extraordinary concern for everyone, especially at accessible pharmacy services, because it's one of the leading, if not the leading cause of blindness in the United States. You can have damage done to your feet, your skin, your hearing, and there's even a link to Alzheimer's. So it's extraordinarily important to manage diabetes appropriately because all of these things, once they start to happen, get very difficult to reverse if it's possible at all. So we talked about the symptoms and we talked about the concerns. Well, how do I get diagnosed with diabetes? Is it enough to just to say I'm going to the bathroom a lot and I'm always thirsty? Well, we have tests that identify diabetes specifically. And the glycosylated hemoglobin, or the A1C, is the hallmark. This is a blood test. It doesn't require fasting, but it kind of indicates your average blood sugar for the past 2 or 3 months. Now, this is particularly important because when we take our blood sugar with a finger test, it gives us a snapshot, what's happening at the moment. But the glycosylated hemoglobin, the A1C test, gives us an idea of what's happened over a longer period of time. So it measures the percentage of blood sugar attached to hemoglobin. Hemoglobin is the oxygen-carrying protein in our blood cell. It's very, very important. Now, the higher your blood sugar levels go, the more of your hemoglobin get bound to sugar. So an A1C level of 6.5% or higher on 2 separate tests indicates diabetes. If your A1C is between, say, 5.7 and 6.4, that's indicative of pre-diabetic circumstances. But if it's below 5.7, it's considered normal. So if for some reason the A1C tests aren't consistent, but you're still having symptoms and other concerns, or if the test isn't available, or if you have a hemoglobin issue that would skew the test or make it impossible to determine, there might be other tests that your physician would choose to use. So a random blood sugar test, and that's just taken at any given moment of time, whether you've eaten or not, that yields a blood sugar over 200 milligrams per deciliter is indicative of diabetes. If you have a fasting blood test, in other words, you haven't eaten for, say, 8 to 12 hours, that's usually taken after an overnight fast, your blood sugar level should be less than 100. Fasting blood sugar levels from 100 to 125 are sort of indicative of prediabetes again. And if it's over 126 or higher on 2 separate tests, you most likely have diabetes. There's also the glucose tolerant test, the oral glucose tolerance test. So for this test, you'd fast, and then they take your fasting blood sugar, and then they give you a nice drink of sugary liquid, and that blood sugar level is tested periodically over the next 2 hours. If after 2 hours, your blood sugar level is less than 140 milligrams per deciliter, excuse me, that's normal. Over 200 is diabetes, and somewhere between 140 and say 199 is considered prediabetes. If type 1 is suspected, your urine will be tested for the presence of those ketones that we spoke about earlier. Your doctor will most likely run some other tests to see if you have some of those destructive immune cells that we spoke of earlier. So here it is. We've gone over what carbohydrates do, how we break them down, why glucose is important, why insulin is important. We know how to test for diabetes. We know how to get a positive diagnosis. What do we do? What do we do? So the reality is, and this is going to be interesting coming from a guy that's made his life medication management, but the reality is the first step is usually lifestyle modification. And just to be honest, healthy eating is never a bad thing, but I guarantee you at some point in time, if you're diagnosed with diabetes, they're going to ask you to talk to a dietitian or a specialist in dietary concerns. So, contrary to what you would imagine or the popular perception, there's really no specific diabetes diet. You'll need to center, your dietary selections on lean proteins, whole grains, foods that are high in nutrition and fiber and low in fat or calories. That's good for anybody. So it's really never a bad idea to do that, but you really want to concentrate on cutting down on saturated fats, refined carbohydrates and sweets, processed foods in general. So if it grew on a tree or in the earth, it's probably good. If it comes in a plastic wrapper, it's probably not. If it comes with a coloring that wasn't made by Mother Nature, God, or otherwise, it's probably not. So if it's processed and it's sugary, it's not a good idea. Now, it's not to say that you can't have a treat once in a while, but it's important when you do give yourself a little deviation from what we would call a healthy diet, you want to include that in your total picture. You don't want to add that on. So if you're having a great piece of, lean chicken or otherwise and some vegetables, you still want to accommodate what you would eat as a treat into your total dietary or caloric thought process. So understanding what to eat and how much is a little bit of a challenge. It's a challenge for anybody. Imagine adding low vision or blindness to the idea of weighing your food or otherwise. So it's extraordinarily important to get help. And a registered dietitian would be a good idea, at least at the onset of your diagnosis, to sort of help establish health goals, food preferences, and lifestyle. That's very important for any professional to know how active you are, what you're doing with your time, and to be honest, what you like to eat. It's important because, listen, none of us can be miserable living, right? So one thing that I keep going back to what we do at Accessible Pharmacy Services, but we're here to empower. We're here to provide an inclusive environment. We want to understand who you are without any kind of judgment or otherwise. We're not going to tell you how to live your life. We're going to tell you how to live your best life. So as it pertains to your dietary selections, be honest with what you like. Be honest with how active you are with any provider, medical practitioner, dietitian, or otherwise. It's also important to try to become physically active. So everyone can benefit by a little bit of aerobic activity, and diabetics are no exception. Exercise lowers your blood sugar. It helps move the sugar into your cells where it should be used for energy. And it can also increase your sensitivity to insulin, which is very, very important because your body will need less insulin to transport sugar into the cells. The one thing we always have to say right about exercise is check with your doctor first, because inherently, if something else going on that prevents you from really intense exercise, you should, be evaluated by your physician before you engage in something like that. Now, we understand that for the blind and low vision community, this can be even more difficult, but there are plenty of things that you can do to stay physically fit while you're blind, or if you're low vision, that can become part of your normal day. So if you're not able to get the 30 minutes of prolonged aerobic exercise, it's also advisable to get up every 30 minutes and engage in 5 or 10 minutes of simple household activities. So there's means and mechanisms to introduce activity into your life that don't necessarily involve putting on running sneakers and going jogging across the street. Obviously, it's not an option, but it's still the kind of thing that we want to talk about because being active is always a good idea. So in terms of pre-diabetes, prior to any kind of diagnosis, there is an opportunity really to stave off moving into type 2 diabetes if you modify your lifestyle. Losing 7% of your body weight can be a very powerful thing if you're carrying a little extra weight around, the activity that we spoke about. Because remember something, every day or every moment that you do not live in the state of diabetes, you're doing your body a tremendous service. So if you're at risk for diabetes, or if you're pre-diabetic and you can sort of stave that off, you're really tilting the scales in your favor. You want to probably think about controlling your cholesterol, your cardiac health. If you have high blood pressure, make sure that that is being looked at by your prescriber. And if you have high risk, your doctor may choose to introduce some very basic medications for diabetes and even some aspirin therapy for people at risk. So, healthy lifestyle choices are always the key, but it's also important to be evaluated by your doctor. So I want to move from pre-diabetes into type 1 diabetes. So as we said, type 1 diabetes, generally speaking, begins at some time early in your life. Your pancreas, unfortunately, is affected. Your body's no longer able to secrete insulin. So now the obvious choice of treatments, besides the healthier lifestyle choices we spoke about, is insulin. But keep in mind something. Insulin, while it is a medication, is a replacement of a chemical that's already in your body, but it's just not present now. So when you think about medications in general, insulin needs to be thought of a little differently. So what we're going to do is talk about the classes of insulin, how they're defined, and then how they're delivered. So there's many types of insulin used to treat diabetes. And although the choices may seem overwhelming at first, there's a sort of what I would call a quick and dirty guide to cut that apart. So what are some of the terms? Okay, so let's talk about onset. And onset is how quickly does the insulin begin to lower your blood sugar? What is the peak? When is the insulin at its maximum strength and doing its best work to keep your body in the place that it needs to be? And then, of course, there's the duration. How long does the insulin work once it's been put into your body? So your doctor will help prescribe, well, talk to you and prescribe the insulin or insulins. You might need more than one based on a couple of factors. One, how active are you? Are you the kind of person that's, getting a lot of exercise? That's important. Having said that, what foods do you eat? How do you like to, how do you like to eat them? How well are you able to manage your blood sugar? What's your age? How long does it take your body to absorb insulin? And how long does it stay active? There's different, I guess what I would call responses for different people. So it's all important to have the information and the discussion with your doctor specifically so that he has the right information to help you make the choice and the plan. And some people, will need more than one insulin, depending on the peaks, depending on the onset, the duration, and how that would affect your blood sugar. So there are a number of different types of insulin. We're going to talk about them in terms of those other factors. So you have the rapid acting insulins. Those act within 15 minutes. Now, generally speaking, the peak time is about an hour later, and they work for about 2 to 4 hours. They're usually taken right before a meal to deal with that bit of carbohydrates that you just ate. And they're often combined with longer acting insulins that cover the time in between the meals. Then there's the regular short acting insulins. That's generally speaking, the onset's 30 minutes, and they peak at 2 to 3 hours, and they work for 3 to 6. And these are also usually taken 30, 60 minutes before a meal. So you look at your rapidly acting insulins and your regular short acting insulins, and they kind of be grouped together as the insulins that are most close to our normal body secretion. Now, it may be difficult for you to utilize these. It may be difficult for you to manage your sugar. We're going to talk about hypoglycemia or low sugar in a little bit. So keep that in mind. While it's important to keep your blood sugar low or in what we would call a normal range, we don't want it so low that we don't feel terrible and we're passing out. Then there's the immediate acting insulins. They start to work 2 to 4 hours after they're injected, and they peak at around 4 to 12 hours. Their duration is 12 to 18 hours. Now, these generally cover the insulin needs for half of the day or overnight. They're often the insulins that are used in combination with those rapid or shorter acting insulins. Then there's long acting insulins. They take about 2 hours to onset, but they don't really peak. They kind of like deliver what we would call a coverage throughout about 24 hours. So it's a full day. And again, we would use these to balance off often those shorter acting insulins that we take in response to diet. And then there's the ultra long acting. They don't really onset until 6 hours. They don't peak as well, and they can last as long as 36 hours, and they provide really steady insulin for very long periods of time. So keep in mind, we've covered a gambit of rapid, short-acting insulin all the way to ultra long-acting insulin, which leads us to pre-mixed or versions or combinations. They tend to act quickly, 5 to 60 minutes, but the peaks can vary depending on the combinations of insulins, and they can generally last for 10 to 16 hours. They combine the intermediate and short acting and usually are taken about 10 to 30 minutes prior to breakfast and dinner. So you sort of cover your 2 big meals as well as sort of the in-betweens. It can be particularly effective for people that can't inject themselves as frequently as others. Something to think about, especially in the blind and low vision community, if you're relying on yourself as the primary administrator of the insulin. So how does insulin get in the body? Well, it sounds counterintuitive, right? You use a needle. And that's true. The 2 most popular versions of insulin applications are in the syringe, which you would draw up from a vial, or an insulin pen. It's basically the same version of insulin. Now, a syringe, you get prescribed a dosage by your physician. You take the vial of insulin, you prep it with alcohol, you draw the insulin up, you look at the insulin. Yes, I said look at it, just to identify the fact that this is not going to be easy. It's not going to be perhaps the most, shall I say, preferred choice for patients in the blind and low vision community. So you can see why it's important to look at the other options as well. Now, the one good thing about this is it does provide a lot of variations, and you can use a lot of different size syringes and size needles. But a lot of those benefits are also experienced by insulin pens. Insulin pens are, a device that use a cartridge of insulin, sort of like the replacement in a pen. Instead of ink, it's insulin. it's relatively easy to put that cartridge into the pen. And then from a tactile perspective, you can count the number of clicks on the dial for the amount of insulin that's drawn up. At the same time, you reuse a very tiny needle at the top of the pen with each injection that's discarded, and you would use a new one the next time. So having said that, we at Accessible Pharmacy Services offer a very, very diverse education opportunity for patients who are utilizing insulin, both as new diabetics, but as diabetics that have been injecting for a while now. We are very well networked with the Be My Eyes application, so we can observe a patient giving themselves the insulin shot and provide them the kind of guidance and feedback that they've done it appropriately. One thing to keep in mind, if you're going to give yourself insulin injections, you really need to vary the sites for each injection. You don't want to do a shot in the same place every time, because the skin and the tissue around it can harden and get a little lumpy. We don't want that happening. So what are the advantages of using an insulin pen or a syringe? Well, it really requires less training than a pump. It's not as long as an education process. It's generally the least expensive way to go. The pens are more expensive than the vials, but over time, they're just much more convenient and certainly easier to manipulate in our community. They also store easier, and they can be used to travel. So insulin pens, specifically in the blind and low vision community, are really a fantastic option. And we provide patients with basically unlimited guidance and direction as it concerns them in terms of getting good at doing this. So some of the disadvantages, obviously, you've got to hit yourself with insulin. You've got to give yourself an injection. And that's not particularly fun for anybody. Having said that, I know that Sherry spoke at length about insurance coverage. And you really have to find the particular insulin that works best for you, that's also covered, to provide you with what we call the least amount of financial out of pocket. Aside from insulin injections through pens or syringes, there's also an insulin pump. So an insulin pump's about the size of a cell phone, and it gives you a basal dose or a small dose of short-acting or rapid-acting insulin every hour. So when you eat your blood sugar, though, you can calculate your dose when you eat food and your blood sugar rises, you can calculate a dose and program the insulin pump to introduce that amount of insulin into your body at the time that you eat. Or you can activate the pump to do so. So it really provides you with a little bit more control over it. And it delivers insulin through a very thin plastic tube that's placed in the fatty layer under your skin. So it's in there. It's not replaced and turned over every single day or multiple times a day, the way that a pen or a needle would be. So the insulin pumps do have a much greater propensity to lower or improve A1C. So they really are effective. They deliver insulin more accurately, and they give you the opportunity to deliver a bolus or a large amount of insulin at a given moment, easier than, say, grabbing the shot or the pen would. You can usually eliminate the unpredictable effects of intermediate or long-acting insulins by giving a little bit all the time, and it can provide you with a little bit better flexibility when it comes to meals or exercise or schedule. And for some people, it's also a well-being moment. If you have a pump and it's working all the time, there's a little bit less to worry about or be concerned with. Now, there are some disadvantages, though. So the first is they're expensive, and not every insurance pays for them, and not under every circumstance. So that's something to keep in mind. As was mentioned earlier, the coverage is important. There's infections at the site of the pump itself, so you have to be careful and keep the area sort of well taken care of. If the machine were to not work properly or stop working, then you could potentially see, a spike in blood sugar, and that can be a big issue. And there's a bit of training that's involved. So it's important to sort of weigh these things out, also in terms of the expense coverage or otherwise, and really have an open discussion with your physician and spend some time exploring all of the options. Now, aside from injectable insulin, there's also inhaled insulin. This is the least used version of insulin, and it offers really sort of what I would call minimal options. But it's usually taken using an oral inhaler and delivers ultra rapid acting insulin at the beginning of meals, and it's most likely combined with injectable insulin. So you really it's almost impossible to escape injecting insulin. So what are the advantages? Well, it's not an injection, right? It acts very fast. And it can be used at the beginning of meals if you're out at a restaurant or otherwise. It just might be a little bit more comfortable to do it that way than to take a needle out or even a pen to give yourself a shot. There's a potential to lower the risk of low blood sugar, but you do see some weight gain, and the device is relatively small, so it can be difficult for some people to manipulate. There are some coughing associated with it. It is more expensive, and the dosages just aren't as precise. So having said that, really, if you're a type 1 diabetic, what's most important is to have open conversations with your prescriber. Explore the coverage of your insulin. Have a plan that best suits your needs in terms of how you eat, how active you are, and what other lifestyle choices that you make on a given day. And again, not to continue with the pitch for accessible pharmacy services, but rely on your professionals. We're here to help in this regard, both in educating you about the types of insulin, what the insulin does and how long it works, but also if there's any kind of injection that you may need to utilize, we're here to help you with that as well. So moving on to type 2 diabetes. Now, type 2 diabetes, if type 1 seemed like a lot of information, this is going to really knock your socks off, because type 2 is just massive. Remember what we said at the beginning of the discussion. You have insulin and you have cells, okay? So you have the insulin that tells the cells to pull the sugar in and use me for energy. So either you don't have insulin, or the insulin that you have doesn't do its job. Well, why wouldn't it do its job? Well, it's the cells aren't sensitive, or maybe there's not enough, or maybe at some point in time, your pancreas just can't keep up. So when you think about that from a broad perspective, we can sort of think about, or at least kind of imagine how the medications for type 2 diabetes will work. Remember, type 2 diabetes is when your body is still producing insulin. It's just not enough, or you're just not sensitive to it. So starting with treatments, again, we're just going to get back to this, and we're going to be quick this time. Lifestyle choices, diet, exercise, and so on and so forth. It's always a good idea. So what treatments would you take orally? What medications would you utilize to lower blood sugar? Well, there's a couple of different classes of type 2 diabetes medications. We're going to talk about them in terms of what they do in your body and classify them that way. So there are some that will stimulate your pancreas to produce and release more insulin. There are some that work to inhibit the production and release of glucose from the liver. Remember, we said the liver stores glucose, and by secreting more glucose into the bloodstream, it can raise your blood glucose and cause that problem. There's also medications that will block the action of the stomach enzymes that break down carbohydrates. When the medications work in your GI to slow the breakdown of carbohydrates, there's less blood sugar available, there's less peaks, and your sugar stays at a normal level longer. There's also some that slow quickly moving foods through your body. And there's some that improve the sensitivity of the cells to the insulin. So we have the insulin, we have the cells. The cells now are more sensitive. And there are some that inhibit the reabsorption of glucose via the kidneys to go back into the bloodstream. So each class of medicine has one or more drugs, and some of these drugs are taken orally and some are even injected. At a glance, a common comparison of these drugs, really, it depends on the situation. You and your doctor have to come to an agreement on which one's best for you. There's a lot of cofactors with this. We're going to go back to the same things over and over again. What is your lifestyle? What's your dietary intake? What is your insurance coverage? Because obviously, if it's too expensive for you to afford, it's not going to work anyway. So very basic, old school medications designed to stimulate the release of insulin, such as sulfonylureas and metiglaninides, were created specifically to bring about more insulin. Now, these drugs work quickly. That's a powerful advantage. However, side effects are low blood sugar or hypoglycemia. We're going to talk about that in a little more detail shortly, but it's something to consider. If your blood sugar goes down too low, you're going to have very, very, I guess what I would call undesirable effects of that. It's not going to feel good. They also produce weight gain, and you can have some GI discomfort as well, especially when you take them with alcohol. For the most part, they're inexpensive and they're effective. Having said that, there's also some that can create some skin irritation. So you really want to measure or I guess what I would call, weigh a lot of these side effects and advantages before you choose, or your doctor chooses. There's also the DPP-4 inhibitors. These medications stimulate the release of insulin when the blood glucose is rising. They can also inhibit the release of glucose from the liver. So these medications don't cause any weight gain. They don't cause hypoglycemia unless they're combined with, another drug that would, or insulin. But they do have some side effects like sore throat and headache and potential for increased respiratory tract infections. It's just something to keep in mind. Then there's the medications called biguanides, which inhibit the release of glucose from the liver and improve your sensitivity to insulin. One of the drugs that we hear a lot about is metformin. So that'll give you an idea of a very popular drug that we hear about often that would inhibit the release of glucose from the liver and improve your sensitivity to insulin. These are very effective. They can produce modest weight loss, which is also desirable, and they're generally speaking inexpensive and covered by most insurances. Side effects include nausea, diarrhea, very rarely the buildup of lactic acid, which can be particularly of concern if you have liver or kidney issues. So you want to be cautious using those in those cases. Then there's drugs that are used to improve the sensitivity to insulin or inhibit the release of glucose. You have drugs like Avandia and Actos. These are the TZDs, if you will. The advantages are that they may in fact help to increase your HDL or your good cholesterol. We said there's a very powerful tie between diabetes and heart disease. So if you can sort of like get the added benefit of better cholesterol, it's a pretty good idea. But these drugs do come with some downsides. There's some weight gain associated with it. There is the possibility of increased fractures, and some people who have had bladder cancer or otherwise need to be particularly wary of them. Theoretically speaking, though, you want to be very cautious while using these if you have kidney disease because of what we said earlier, or if you have heart problems. And I know I said that it, may slightly increase the good cholesterol, but if cholesterol is an issue in general, and it's not so much the balance, but the amount, you don't necessarily want to increase any cholesterol. Then there's the drugs that would be used to slow the breakdown of starches and some other sugars, the AG inhibitors. The good news about these medications, they don't cause any weight gain. They don't cause hypoglycemia, again, unless you're combining them with other drugs that do. They do have some GI discomfort, stomach pain, gas, diarrhea, or otherwise. And if these things become an issue while you're taking the medications, report them to your prescriber because they're just not the right drug for you. Let's get back to one thing I want to keep in mind. When you're taking medications, you cannot suffer more greatly because of the medication itself than disease, right? So if you're taking something that's worse than disease itself, it's not the right choice for you. Fortunately, there's plenty of drugs and plenty of drug classes to go to. So really, there's no need for you to stay quiet and suffer in silence with this. If you're having any side effect that's undesirable to the point where your quality of life is being affected, you have to report that back to your doctor. If you're coming to Accessible Pharmacy, we'll be very happy to catalog this for you, and we'll call your doctor. We'll give them the poke or the prod to sort of, get you into a drug or a class of drugs that would be better suited for your lifestyle. Then we're going to move on to the Sglt2 inhibitors. These block glucose from being reabsorbed through the kidneys. Now, these drugs are generally very expensive, but they're also very effective. They promote weight loss. They can also lower blood pressure. The problem is because they're acting in the kidneys, they can, have some undesirable effects. You can have urinary tract infections, yeast infections, and some, other rare issues with urinary tract that you really want to be careful of. So if you're prescribed them and they're working great, you're not experiencing any of those side effects and your insurance is willing to pay, that's great. However, if they're not paid for by your insurance, as was spoken earlier, we can pursue prior authorization or otherwise. But if they have any kind of effect on your urinary tract that's undesirable, frequent urinary tract infections or otherwise, you want to speak to your doctor and get these discontinued. So moving on, that's basically an overview of the oral medications used for type 2 diabetes. Having said that, there's also some injectable products that aren't insulin. Okay, let me say that again. I know it sounds crazy because we've talked about insulin as an injectable product specifically for type 1, but there are also injectable medications that you use for type 2. There's insulin that would help regulate glucose, by slowing, slowing food moving through the stomach. They can also augment the usage of insulin. They suppress hunger. They promote some modest weight loss. And these drugs are the amylin mimetics. A drug like Similin is an example of those. They do, however, open the possibility for hypoglycemia or low blood sugar, and they can cause some GI issues like nausea or vomiting. You're going to hear GI issues a lot. Remember, this is carbohydrates, dietary intake, breakdown through the stomach, and we're going to work in different, time and places through that system. And that may bring about a side effect that you don't particularly like or otherwise. But it's important to be open with your doctor and be open-minded before you use them too, because really what's most important is we keep your sugar in check and keep you healthier for as long as possible. So then there's the Glp-1 analogs. These stimulate the release of insulin, and they're most often used with metformin or basal insulin or sulfonylurea. Those are the drugs that help your body be more sensitive to insulin. So now we have a drug being used to increase the sensitivity, plus a drug that stimulates the release of insulin. So you're sort of covering both areas of the teeter-totter there. There's a number of these. They're particularly expensive. Some advantages are they suppress hunger and they produce a little bit of weight loss. That's always a good thing. But they can create some of those GI discomfort that we spoke of earlier. And for some people, especially those that are at risk for pancreatitis, you may want to be wary of the use of these drugs. So having said that, that encapsulates, my God, what a menu of opportunities and what a menu of drugs to choose from. The most important thing when you're considering using any oral medication or injectable for type 2 diabetes is the plan, okay? The plan, your other health issues. Are you active? How are you eating? What are you eating? When? And so on and so forth. Let us help you with this. Please, we're a resource of information. Whether you're getting your pills from us or not, we're very happy to provide you information. The most important thing for any diabetic is having the education and understanding to empower themselves to assist in the process of the choices of how they would treat their medications. Just as a simple closing though, it is true that after all of this, some type 2 diabetics still require insulin. If for some reason you need insulin, it is not a progression to type 1. You still have type 2. They're two different diseases and they're brought about by different things. The other thing is that needing insulin doesn't mean that you failed at the other interventions. It's just that if you get to the point in time where you can't control your type 2 diabetes with what we would call lifestyle modifications and the traditional oral and non-oral options, insulin may become an option for you. And that's just sort of the way things are. And that's just something to keep in mind. If it happens to you, just don't think of it as anything other than another medication or option. So we've talked about the types of diabetes. We've talked about the role of sugar and the role of insulin and medications or otherwise. But I want to talk about the flip side of this for just 1 second, because if we're going to be pushing all of that sugar out of your bloodstream and into your muscles and into your tissues and the places where it needs to be, we have to talk about the process of overshooting or low blood sugar, which clinically is known as hypoglycemia. If your sugars drop too low or below your target level, if you're taking medications that lower your blood sugar, including insulin, and for any number of reasons, or if you skip a meal, if you're more physically active than normal, your blood sugar could lower to the point that it creates a problem for you, and that is known as hypoglycemia. So you want to check your blood sugars regularly and watch for signs and symptoms: sweating, shakiness, weakness, hunger, dizziness, headache, blurred vision. You can have heart palpitations. You could be slurred speech, irritable, drowsiness, confused, dizziness, or otherwise. That's important for people who are around those that are diabetic, because a lot of times, I'm trying to think, I believe Steel Magnolias, if you remember the scene where Julia Roberts was getting upset, her blood sugar went too low. She became shaky and aggravated and almost nonverbal. I know she has an Oscar, at least I think she does, and she deserved one for that because that was a really good depiction of hypoglycemia. But when this happens, you need to treat it immediately. It's considered an emergency, and it should come as no surprise. But the way to do that is with carbohydrates. Fruit juice, glucose tablets, or otherwise will help pull you out of hypoglycemia. Having said that, if that doesn't work, or if you're using insulin and you've taken so much that you can't overcome it with um, dietary intake of sugar, it may be necessary to use glucagon. Glucagon, like diabetes, or I'm sorry, I beg your pardon, like insulin, is a hormone produced in your pancreas that is released to stop blood sugars from dropping too low. So you can give glucagon. They have something called a glucagon kit or an emergency. It's necessary for most diabetics to have one, especially the insulin diabetics, to have a glucagon kit on them for this reason. When would you use an emergency glucose shot? Well, if you're unable to eat or drink safely because you're confused or you're disoriented, if you're unconscious, or if you are having a seizure. So if you are a diabetic, it's important to have a glucagon kit with you. It's important for your support network, the people around you, to understand what it is and the symptoms of hypoglycemia. So here we are. We've got this diagnosis. We've gone through lists and lists of testing or otherwise. How do we monitor? Well, there's two specific parameters, right? There's blood sugar and there's A1C. So blood sugar is what we call glucose or blood glucose. And then there's the A1C. The A1C is that glycosylated hemoglobin, and that's really a discussion about how well your sugar is being managed over a period of 2 to 3 months. It provides clinicians with a really good idea of how good you're doing and where you are in your diabetic pathway. So generally speaking, if you have pre-diabetes, then they'll test your A1C once a year. But they could use that. But if you are type 2 and you are not using insulin, you're most likely to get it tested twice a year and 4 times a year if you have if you're using insulin, or if you're just not well controlled. It may be more frequent if your doctor is changing your therapy often, or if you begin a new medication. So A1C is sort of the clinical indicator. Having said that, on a daily basis, the home mechanisms to test or monitor for diabetes is generally blood glucose testing devices. So there's hundreds of blood glucose testing devices. And for diabetics, it's glucose meter is just part of their life. But which one, to use really matters. So traditionally speaking, the traditional blood glucose devices involve a 3 or 4 step process. So you'll have the prep of your finger, right? So how do you do that? You run it over warm water. You try to draw blood to the extremity. Then you have an alcohol prep, which will sterilize or clean the area prior to a finger prick, where you use a small device, a pen or otherwise, to open a small hole in your finger to create a drip of blood. That drip of blood goes on a strip. The strip pulls the blood in, and then that strip with the blood goes into a device. The device will have a readout. Now, the readouts are generally very big. Doesn't do you much good if you can't see at all, and potentially if you have low vision. But it's something to keep in mind, because this is the kind of thing that's out in the marketplace, and maybe not the best thing for a blind or low vision patient, but it's the majority of them. Now, there are some that speak, so that's great. Once the test has been completed, it'll say your blood glucose is this number. Okay, but you still have to go through the entire process that I just spoke of. So if for some reason you were to need or want to utilize these kinds of testing devices, we can certainly help you with that. We can certainly educate you as to the product and walk you through the process. It doesn't mean that every person that's blind or in the low vision community is going to be able to do this. Having said that, we spoke earlier about this, there are continuous blood glucose monitors that are available. And the two that are most frequently spoken of are the Libre and the Dexcom 6. So the Libre 2, or the newest version made by Freestyle, and Dexcom 6 made by Dexcom, are both continual glucose monitors. Now, there's more choices coming about every day, and I'd assume that in a short period of time, there'll be many new ones, but fancier and newer isn't always better. So here's some things to consider. First and foremost, the ease of use. Okay, so really, whether it's a large button or large tactile features, it's important that you have one in your hand before you decide to pick it. The variations and the variability of the meters or monitors to, I guess what I would call, provide you with more data is also important. Some monitors will keep you track of your sugars for months and months and months. And that's a great thing. or maybe it's not if you're always very precise. But those features are out there. It's something to keep in mind. But having said that, if you can get a continuous glucose monitor, you're going to prick your finger less often, and that's very desirable. So whether you're type 1 or type 2, continuum monitoring might be a good idea, especially if you're in the blind or low vision community, because it's less intrusive on a daily basis. It's less that you have to manipulate and gain proficiency in. So when you have a continual glucose monitor, basically you have a sensor of some kind. The sensor is placed on your arm or potentially your abdomen for 10 or 14 days, depending on the product. Some of the sensors have a reader in them, and others you have to put the reader, or shall I say, the sensor on top of where the the product is inserted into the body. From there, it's sending constant information to a reader or a smart device. For the most part, your cell phone or a tablet or otherwise can act as that device. So your blood glucose is being tested all the time or read and sent to your smart device on a scheduled basis in variations depending on your meal. So it can be a very, very effective tool. And having said that, we, again, will assist you in getting it covered, billing the insurance, and then training you on this. The other cool thing about the continual glucose monitors is they provide a number of different bits of information. And over a period of time, they're going to be, I guess, really what I would call the next step in diabetes treatment monitoring or otherwise. So it's very, very important to monitor your blood sugar. It's important to check in with your physician so that your A1C is also monitored, because your blood sugar is really only telling you the story at the moment, right? But your A1C is sort of your report card, if you will. It gives you a better idea over time of how your diabetes has been controlled or maintained. So basically, to sort of sum up this massive amount of information that I presented to you, hopefully we're rounding the corner into the home stretch, and I can see it's now 4 p.m. on the East Coast. It's happy hour somewhere. I'm going to provide you with a little bit of a closing and a summary. So to keep in mind something, carbohydrate intake is the part of normal diet. It is. There's no specific diet for diabetes in general. Healthy lifestyle choices are always a good idea. Processed carbohydrates, concentrated fats are usually not a good idea and something that should be avoided at almost all costs. Be it type 1 or type 2, there is a massive menu of options for your treatment. No one thing is right or specific to any given person. It really becomes about you getting to know your diabetes, your body, your lifestyle, and also your quality of life once you've introduced the agents. Continuous information is always wise, and connectivity to your prescribers and also to the people like Accessible Pharmacy that can support you in terms of education, affordability, or otherwise. Have a plan. Be part of your own diabetes treatment regimen. Concentrate on healthy lifestyle choices. And most important, rely on the resources that are available to you to reduce your burden and to just have diabetes be a quiet or smaller part of your life than maybe what most people would anticipate that it would be, need to be. So just in closing, I want to thank everybody once again for all of the previous discussions. Thank you all for the time you've given. I hope that this has been helpful. I hope that the information presented was in a way that can make things easier and better for you. And just as a simple close, please follow what Alexandra said. Give us the feedback from this discussion. Provide us with any kind of considerations or otherwise. We have been so fortunate and privileged to speak to so many of you and learn from so many of you. So again, I want to thank you all for the time. I want to thank you all for the opportunity to speak, and want to reiterate that Accessible Pharmacy Services is here to help in any way that we can in the diabetic community, be they blind or caring for a blind or low vision individual. Thank you so much.